Hello everyone and welcome to the topic on disorders of bone. So the learning outcomes of the BDS curriculum for this topic are as follows. By the end of the topic, you should be able to categorize bone disorders affecting the maxillofacial region, differentiate clinico-pathologically between three types of fibrous lesions, describe the management of fibrous lesions, illustrate the histopathology of fibrous lesions, central giant cell granuloma, and osteosarcoma. And lastly, describe the oral manifestations of metabolic and endocrine disorders of bone. So first, let's look at how do we categorize bone disorders in general. So mainly they are categorized as inherited and developmental disorders, inflammatory disease of bone, metabolic and endocrine disorders of bone, tumors of bone, and diseases that are categorized as tumor-like lesions, categorized namely Paget's disease and central giant cell granuloma, and other lesions. Now, in this lecture, basically, I am going to focus on some of the most important topics, which would be fibrous lesions, dry socket osteomyelitis, Paget's disease, central giant cell granuloma, and osteosarcoma, which are important topics under the bone disorders that as an undergraduate you should be knowing them very well. So let's look at fibrous lesions. Okay, so let's first see what is fibrous lesions. So fibrous lesions are a diverse group of processes characterized by the replacement of normal bone by fibrous tissue containing a foci of mineralization that vary in amount and appearance. So this explanation is one of the most important aspects of understanding what is fibrous lesions. So this is a very, first of all, this is a process, right? And is a group of lesions where what really happens is that the normal bone gets replaced by fibrous tissue, and then in that fibrous tissue there is foci of mineralization that develops, and slowly that foci of mineralization constantly may increase in amount. Okay, now based on this uh, uh, characteristic process, so the WHO has classified fibrous lesions of the maxillofacial region area over the course of many years. Okay, and one of the latest classification is the 2017 classification, wherein fibrous lesions, that means lesions of the head and neck, wherein the bone is replaced by fibrous tissue, and then the fibrous tissue undergoes mineralization, is categorized as follows. All right, so number one in that list is fibrous dysplasia. Okay, under fibrous dysplasia we have three types. We have monostotic fibrous dysplasia, polyostotic fibrous dysplasia, and craniofacial dysplasia. Now monostotic is when one bone is affected. Polyostotic is, poly means many, ostotic means many bones are affected. That's when you call it polyostotic fibrous dysplasia. Craniofacial fibrous dysplasia is specifically when the bones of the craniofacial region are affected. Second category is cementoscious dysplasia. Okay, so cementoscious dysplasia, also abbreviated as COD. Okay, under that you have periapical, focal, florid, and familial gigantiform cementoma. The third is ossifying fibroma, which is further classified as conventional ossifying fibroma and juvenile ossifying fibroma. So now I'm going to explain further about this classification and these lesions as we go forward. Right, now when we look at fibrous lesions, right, as we've understood, normal bone is replaced by fibrous tissue. That fibrous tissue undergoes mineralization. That's what is fibrous lesions. It's a process. All right, now these fibrous lesions collectively are categorized into three types. All right, developmental lesions, which is what is fibrous dysplasia. Reactive lesions, that means they occur secondary to inflammatory components, which is cementoscious dysplasia, and the third component, which is neoplastic. Neoplasm means new growth, and under which comes the benign neoplasm ossifying fibroma. So at the previous slide, the 2017 classification, basically if we look at it, fibrous dysplasia under which we have monostotic, polyostotic, and craniofacial. Cementoscious dysplasia, under which we have periapical, focal, florid, and gigantiform cementoma, cementoscious dysplasia. And under ossifying fibroma, you have conventional ossifying fibroma and juvenile ossifying fibroma. So when you look at their origins, they are categorized as developmental lesions, reactive lesions, and neoplasm. All right. Now, what is the difference between the three? Developmental lesions basically arise during the early life of a child. They increase in size as the child attains puberty, and once the growth potential is stopped, the lesion is believed to stop growing. So basically, these lesions, developmental lesions, are generally self-limiting, right? Reactive lesions are lesions that occur secondary to inflammation. So that means cementoscious dysplasias typically arise in tooth-bearing areas in the periodontal region, and inflammation of the periodontal apparatus is one of the causes of this lesion. Neoplasm, on the other hand, is new growth, right? So new growth, the difference between developmental lesions and neoplasm is that neoplasms do not stop growing, right? So basically, once there is that mutation that has taken place and a lesion starts to proliferate and grow, this benign lesion has a constant, persistent growth potential, as against developmental lesions, which will stop growing once the growth phase of the child is over. Okay, I hope I've made this clear. Let's look further now. So number one, let's look at fibrous dysplasia. Now, fibrous dysplasia is a developmental tumor-like condition characterized by replacement of normal bone by an excessive proliferation of cellular fibrous connective tissue intermixed with irregular bony trabeculum. So that is the same process as fibrous lesion, right? Now, this occurs because of a mutation, all right, and the mutation that takes place is basically this GNAS gene, right? So, which leads to a defective protein. So, guanine nucleotide binding protein, alpha stimulating activity polypeptide 1 gene, right? So, this protein, when it is defective, it leads to fibrous dysplasia. Now, fibrous dysplasia can be majorly of two types, all right, monostotic and polyostotic. So, as I already told you, when one bone is affected in the entire body, it's called monostotic. When many bones are affected, it's called polyostotic, right? And craniofacial is when maxillofacial region is affected. So, let's look at these two major types. So, monostotic fibrous dysplasia of the jaw, the clinical features are it's limited to a single bone. 80 to 85% of all cases are monostotic fibrous dysplasia. Now, jaws are most commonly affected. Second decade of life, most common age of occurrence. There is equal sex predilection. That means there is no particular gender that is commonly affected. Painless, it arises as a painless slow growing swelling of the maxilla, all right, commonly affecting the maxilla. Okay, so radiographic features in the early stages, all right, there is mixed radio opaque radiolucent lesion, or the appearance is also described classically as ground glass appearance. Now, the lesion is not well demarcated, all right, and it has very most times it has diffuse margins. Periapical radiographs show narrowing of the peripedial space with ill-defined lamina dura. So these are classical features of fibrous dysplasia. So here we have a case here. This is and there is an expansile mass of the left maxilla here that we are seeing, right? When there's a swelling like this, definitely there is discomfort in eating, chewing, swallowing, as well as speech, and then the patient turns up to a dental school or to a dental practitioner. When you After clinical examination, when you do the radiographic examination, you notice that there is diffuse ground glass appearance, right? Again, on OPG also, you're able to see a diffuse ground glass appearance that is very clearly evident, and our provisional diagnosis would be fibrous dysplasia. Now, polyostotic fibrous dysplasia is when multiple bones are affected, right? So fibrous dysplasia affecting many bones is called polyostotic fibrous dysplasia. Now under polyostotic fibrous dysplasia, we have two syndromes that have been identified. Number one is Jaffe-Lichtenstein syndrome, and number two is Mckinney-Albright syndrome. So let's look at what these syndromes are. So first of all, polyostotic fibrous dysplasia is not very common, right? As you're aware, it affects multiple bones. Yes, of course. Now, when you see fibrous dysplasia affecting multiple bones, plus there is cafe au lait pigmentation, or the pigmentation which is described as coffee with milk. Previously in various other topics, I have explained what is cafe au lait pigmentation, right? So cafe au lait pigmentation is basically coffee with milk pigmentation. When you see this skin lesions in association with polyostotic fibrous dysplasia, then it is described as Jaffe-Lichtenstein syndrome. When you see features of Jaffe-Lichtenstein syndrome, plus there are multiple endocrinopathies, then it is described as Mckinney-Albright syndrome. Okay, so this is how polyostotic fibrous dysplasia, Jaffe-Lichtenstein syndrome, and Mckinney-Albright syndrome are identified. Okay, so now let's look a little more detail about what is cafe au lait pigmentation. So cafe au lait pigmentation basically is coffee with milk pigmentation. So they are well defined unilateral tan macules, all right, commonly seen on the trunk and on thighs. They have irregular margins, all right. Okay, they have irregular margins. If these cafe au lait pigmentations have smooth margins, then we should be worried about neurofibromatosis. Okay, they are present since birth, so they are congenital and pigmented oral. This is a picture here of a patient, okay, who has maxillary unilateral maxillary expansion, okay, enlargement of the right maxilla and the mandible, right, which is evident here on this picture. And this patient has cafe au lait pigmentation, right? So this is basically, so this patient is a white skin patient, right? So basically complexion is fair, and then you are actually able to appreciate these tan macules on the skin. So when you see irregular margins, then we are looking at Jaffe-Lichtenstein syndrome. If this cafe au lait pigmentation has smoother margins, then this is not Jaffe-Lichtenstein syndrome, but we're looking at something else. More commonly, it could be neurofibromatosis. Now, Mckinney-Albright syndrome, all right, so is all features of Jaffe-Lichtenstein syndrome plus multiple endocrinopathies. Now, when we talk about multiple endocrinopathies, it could be sexual precocity. So, sexual precocity basically means when when a female, okay, attains early puberty, right? So menstrual bleeding that is seen in the few months of life, breast development and pubic hair in the first few years of life, right? So this is because of an endocrinopathy, all right? There are other endocrinopathies that have also been identified in patients with Mckinney-Albright syndrome, such as pituitary adenomas or hyperthyroidism. Okay, now this pattern is classified is described as Mckinney-Albright syndrome. Okay, so here we can see a CT image here, right, of showing the skull and the maxilla. So here we are seeing extensive involvement of the maxilla and skull. So when when the maxilla is involved, the lesional tissue generally displaces the sinus floor superiorly and commonly obliterates the maxillary sinus, which is clearly evident in this case. Okay, and when the skull and the maxilla is involved so extensively, it is more towards craniofacial fibrous dysplasia. Right. The second photograph here is actually a continuum of the case that I showed you, where you've seen the maxilla and mandible uh, swelling, as well as the radiograph here and the cafe au lait pigmentation. So this is that patient, and who's diagnosed with Jaffe-Lichtenstein syndrome. So under polyostotic fibrous dysplasia, we have Jaffe-Lakenstein syndrome, and Mckinney Albright. Okay, so let's come to the histopathology. Either way, any whichever type of fibrous dysplasia will have the same histopathology based on where the specimen is taken from. So because this is normal bone replaced by fibrous tissue which gets mineralized, what we generally see in histopathology is irregular shaped trabeculae of immature bone in cellular loosely arranged fibrous stroma. The bony trabeculae are not connected to each other. You see curvilinear shaped, which is described as Chinese character or Chinese script writing. Okay, it's not surrounded by plump osteoblasts, so osteoblastic rimming is not seen. Tiny calcified spherules are rarely seen, and generally this microscopic image of fibrous dysplasia is described as monotonous pattern. So this is the microscopic image. So basically this is the fibrous tissue, this is the mineralized component that we are seeing. Okay, so normal bones, obviously if we've taken this specimen from the swelling in the maxilla, so if this was normal bone then we would have seen cancellous bone, but here cancellous bone has been replaced with mature fibrous tissue which is further undergoing mineralization, and this is basically the curvilinear pattern of mineralized ossifications that are, and this is the hyper image of the slide. Basically you're able to see the ossification, but there is no osteoblastic rimming that is visible. Okay, so in fibrous dysplasia, 0.4 to 1% chance of malignant transformation is seen. Monostotic is when single bone is affected. Usually it affects the maxillofacial region. When a patient has polyostatic, generally the bone that is affected is femoral and maxillofacial. And in terms of malignant transformation that can take place in fibrous dysplasia, the highest chance of malignant transformation is osteosarcoma, followed by fibrosarcoma, and lastly chondrosarcoma. Okay, so I would like to mention here that when we spoke of fibrous dysplasia, we're talking about it under the category of developmental type of fibrous lesion. So, as you're aware, developmental lesions are will stop with once the child finishes the growth spurt. So these lesions generally regress and can be managed once the growth phase is over. But many a times, if the lesion continues to grow, causes asymmetry and leads to facial deformity, then it is treated um, with surgical recontouring. Okay. All right, so let's move to cementoscious dysplasia. So cementoscious dysplasia, previously in the 2005 classification of the WHO, was called osseous dysplasia. Now, these lesions, these fibroosseous lesions, is among the most common ones that we see in dental practice. Right? They occur in tooth-bearing areas of the jaw. They're the most common fibroosseous lesions. The possible etiology that it has been attributed to is periodontal ligament origin, basically a defect in the extra ligamentary bone remodeling, and some hormonal imbalance, which leads to uh, these lesions. Now, these lesions are clinically and radiographically categorized as four types: periapical, focal, florid, and gigantiform cementoma. So let's look at each one of them as we go. So number one is periapical cementoscious dysplasia. So as the word goes, it's periapical, so it's commonly seen in the periapical region. Most common area that it affects generally is the mandibular anterior teeth, right? So there is a female to male predilection of 10:1. That means more commonly in females. The ethnicity that is commonly affected, the race that's commonly affected is blacks. Between the age group of 30 to 50-year-olds, all the mandibular anterior teeth will be white. Okay, so in this case we're talking about a fibrous lesion. So again, I'm going to bring your thoughts back to the process, right? The explanation of the process. Fibroosseous means normal bone replaced with fibrous tissue. Fibrous tissue undergoes mineralization. Here in this case, this is happening in the anterior mandible, right? That means affecting teeth, mandibular anterior teeth. all those teeth, when you check the vitality, will be vital, but the periapical bone will show this fibro-osseous change. So when this fibro-osseous change is taking place, the bone will show radiographic changes, which I will explain moving forward. So these patients are generally asymptomatic, so there's no complaint as such, and these lesions seldom exceed more than 1 centimeter in size. Okay, so radiographically, there are three stages, right? The early stage, obviously, since this is normal bone that is being replaced by fibrous tissue, you're going to see circumscribed area of radiolucency, apical area of the tooth, right? So if we are looking at, let's say, 3-1 and 4-1, this patient has come for a routine checkup, and suddenly you see a radiolucent lesion attached to the periapex of 3-1, 4-1. Of course, you're going to think of some periapical pathology, but before you jump to conclusions, you need to check vitality. If the tooth is vital, then there is a very high chance that this is an early lesion of a fibro-osseous lesion of the type periapical cementoscious dysplasia, right? With time, this radiolucency goes on to envelop the apices of the teeth, and as it matures, this radiolucent lesion will develop radio-opaque specks and radio-opacities, right? As the lesion matures, there will be more dense calcifications that surround, but there will be a radiolucent rim. So this is what I mean. So multiple radiolucent lesions that are seen at the apex. You see one, you see two, three, four, right? Now, during late stage, these same areas basically they show opacities, later exhibiting significant mineralization, right? So there is radio opacity around that. There is a rim of radiolucency, right? So these clearly show various different stages of periapical cementoscious dysplasia. Of course, here in this image, you're also seeing a crown that has been put, a fixed partial denture that's been put, right? There's a missing tooth here, and so um, periapical cementoscious dysplasia come under the category of reactive. So there has to be some reactive process which leads to this periapical change. Now it's very easy to be misled that because of these processes that is present, this lesion could be a cyst or a granuloma, but you've got to take care and you've got to assess what uh, is whether the tooth is vital here, because here RCT has not been done, right? So if these teeth are still vital, then definitely we are not looking at a periapical pathology, but we are looking at a very fibro-osseous lesion, more commonly a PCOD. Okay, so if you really do a biopsy of this lesion, what are you going to see? You're going to see fragments of cellular mesenchymal tissue, fibroblasts, collagen fibers with numerous blood vessels, and a mixture of woven bone, lamellar bone, and cementum-like particles. Right? How do we identify cementum-like particles? As we've discussed during the various slide discussions, cementum is always basophilic on H&E. Right? So if we see basophilic calcifications, more or less they are cementum-like particles. A final radiopaque stage, if a biopsy is taken when it's final radiopaque stage, then you're going to see more trabeculae fuse and which form lobular masses composed of sheets of acellular disorganized cementoscious material, right? Right, so this is what we mean here. So fragments of cellular connective tissue containing trabeculae of bone, okay, spicules of cementum, like particles with moderate stroma. So all this pink area is basically your fibrous tissue. These basophilic areas are cementum-like areas, all right? So at late stages, you see basically sheets of these sclerotic masses of cementum and osseous material. Okay, so what is the difference between periapical COD and focal cementoscious dysplasia? Well, when only one site is involved, that means one tooth is involved, then we call it focal cementoscious dysplasia. Periapical cementoscious dysplasia affects all the anterior mandibular teeth. Okay. Again, there's a female predilection, affecting the third to the sixth decade. Any area of the jaw can be affected, but the most common area is posterior mandibular teeth. Lesions are asymptomatic and smaller than 1.5 centimeter. Many times it is believed that these focal cementoscious dysplasia are a transition to multifocal involvement. So basically, at what time a patient comes to the dentist, at what time you have, at what stage of the maturation of the lesion you have taken the radiograph, you will be coming up with a diagnosis. So this is a radiograph, right? Clearly showing mandibular posterior teeth, right? Which shows a radiolucency over the course of time. The same patient, after many years, after 9 years, shows radiopacity. So at this point, when this patient has come, if this tooth is vital and this radiolucency is present around, then most probably this is a focal cementoscious lesion. Right, so let's look at the next one, which is florid cementoscious dysplasia. So when we use the word florid, it means multifocal involvement. What is meant by multifocal? Multifocal means more than one. So usually they are bilaterally present and symmetrical involvement is seen. And again, the lesions are very similar to the previously described periapical and periapical cementoscious dysplasia. Female predilection is seen, right? Now, the difference between florid cementoscious dysplasia and gigantiform cementoma is that in gigantiform cementoma, there is all four quadrant involvement, right? So it is more aggressive, and it is previously was used as a synonym for florid, but now it's not. Okay, it's also been identified that familial gigantiform cementoma is an autosomal dominant disorder that demonstrates very high penetrance. That means if either of the parent has it, the immediate offspring has a very high chance of having the same lesion. Okay, again, more or less, most other features are very similar to the previous described lesions. And this is the florid cementoscious dysplasia example. So you're seeing yellowish avascular cementum-like material, which is beginning to exfoliate from the mucosa. When a radiograph was done, what was noticed is multifocal radiopaque lesions of the posterior areas of the jaws are seen. Look at this area, look at this area, look at this area, right? So this is florid cementoscious dysplasia. Now, these lesions, management of these lesions, generally, if patients are symptomatic, the management is quite difficult. Okay, it depends on the stage and depends on the symptoms and the difficulty that the patient is having. Many times, this bone, the sclerotic components basically are surgically recontoured to basically try and treat the complaint of the patient here. Okay, so now let's look at ossifying fibroma. Now, ossifying fibroma is a neoplastic type of fibrosis lesion. That means that it has a certain amount of growth potential and continues to grow unless and until it is treated, right? That is the difference between developmental lesion and a neoplastic lesion. Now, under ossifying fibroma, we have two types, conventional and juvenile. So let's first look at conventional ossifying fibroma. So it's a true neoplasm with a significant growth potential, as I've already told you. It resembles focal cementoscious dysplasia radiographically and to a lesser extent histopathologically. All right. Now, the etiology has been believed to be odontogenic or periodontal ligament in origin. The neoplasm is composed of a mixture of bony trabeculae, cementum-like spirules, or clinical features. It commonly affects third to fourth decade of life. Female predilection again seen. Mandibular, premolar, and molar region most common area. It rarely erodes or displaces teeth and are slow growing and expansile. So these patients basically come with a swelling of the jaw of the mandible, and when you actually examine them and you do the radiograph, you will be able to identify these lesions in these areas. Larger lesions are generally painless swellings of the involved bone. Chief complaint of the patient usually is asymmetry. Radiographically, what we see will be a well-defined and unilocular mixed radiopaque lesion, right? Commonly, root divergence or resorption of roots of the associated teeth is rare. So let's look at this here. There's a maxillary enlargement of the posterior maxilla, mixed radiopaque radiolucent lesion that is seen. Okay, now this is actually a rare case. More commonly, ossifying fibromas affect the mandible. So histopathologically, so again, it's a fibrous lesion, so fibrous tissue, varying degree of cellularity is seen, contains mineralized material. Now the hard tissue portion may be in the form of osteoid, so that means bone-like, and bone, or basophilic and poorly cellular spherules-like structures or cementoid-like material. Now, peripheral osteoid and osteoblastic rimming is present. So that is the histological difference between fibrous dysplasia and the major difference between fibrous dysplasia and ossifying fibroma. So this is the microscopic image. So mixture of woven bone and cementum like this basophilic is cementum. All of this is fibrous tissue. This is the bony trabeculae that you're seeing, or the osteoid. Okay, same thing. So well circumscribed solid mass of tumor. That's why you're seeing a clean cut here. All right, trabeculae of bone and droplets of cementum like material in the background of fibrous connective tissue. So whenever we're talking about fibroosseous lesion, it's basically normal bone replaced by fibrous tissue. So microscopically, if you can identify fibroblast, collagen, osteoid, you should be able to identify these under the microscope at the undergraduate level. So coming to treatment now, since ossifying fibroma, conventional ossifying fibromas are well circumscribed lesions, that means generally they will have a well-defined mixed radiopaque lesion with a peripheral rim, right? They are easily enucleated, so they can easily be enucleated, and the prognosis is good. So there is the recurrences are rare, malignant transformation is not seen. So that's good news about ossifying fibromas. On the other hand, when we look at juvenile ossifying fibromas, now juvenile ossifying fibromas, these lesions are different from conventional ossifying fibromas because of the age of occurrence, okay, the site that it commonly affect, and the clinical behavior. So let's look at it. These, first of all, age of occurrence, mean age of diagnosis ranges from 11 to 22. They have a male predilection as against conventional ossifying fibroma, which is female predilection. The site is maxillary predominance, all right, more commonly seen in the maxilla. And the two histological types are trabecular and pneumoma type. Okay, clinical behavior wise, these lesions are more aggressive than conventional ossifying fibroma. So if the lesions are small, they are treated with excision. If the lesions are large, then they are treated with curettage. Now the prognosis of juvenile ossifying fibromas is fair to poor, because the recurrence rates are very high. That is 30 to 50% recurrence rate that is seen. Okay, so this is the general outline of fibrous lesions. There are a lot more content that is available for you to understand the core concept I have explained here. More discussions we will have when we actually discuss the CBLs in the lab. All right, thank you. Okay, so now let's look at inflammatory lesions of the bone. So under that we have dry socket and osteomyelitis. So let's look at both of these. So by definition, dry socket, according to Blum, is postoperative pain in and around the extraction site, which increases in severity at any time between and 3 days after extraction, accompanied by partial or totally disintegrated blood clot within the alveolar socket, or with alveolar socket with or without halitosis. Okay, so this is basically which explains the entire process. So basically, after extraction, within 3 days, the patient comes back to you with severe pain. When you actually examine the socket, you identify that the clot has disintegrated, and these patients have severe halitosis. So if this is some historical background and various different names by which it is called. It's also described as alveolar osteitis, alveolgia, localized osteitis, various different names. All right. It's even described as localized osteomyelitis, and probably most accurate of all, fibrinolytic alveolitis. Okay. Okay. Now this is a clinical picture of a patient who has reported to a dental clinic exactly 2 days within 3 days after extraction. And what you notice here is basically that the extraction socket has not healed and there is dislodgement of the clot. Okay, so this is a clear example of clinically dry socket. Okay, if you take a radiograph of the socket, there's nothing pathognomic about it. Basically, you'll be able to see the socket and the dislodge. Etiology basically is oral microorganisms, traumatic extraction, roots or root bone fragments that are remaining in the wound, excessive irrigation or curettage of the alveolus after extraction, which is the cause of dislodgement of the clot. Physical dislodgement of the clot and smoking. Now, smoking is a very important contributing factor, and that's one of the reasons why smoking is patients who undergo extraction are advised not to smoke for at least 3 to 7 days until the healing process has taken place. So the pathogenesis for dry socket is described by Byrne as the fibrinolytic theory. Basically, what happens is whenever there is traumatic extraction that takes place, it leads to inflammation of the bone marrow, right, which releases tissue activators, right, and these tissue activators basically break down the plasminogen into plasmin, and this plasmin causes the lysis of the fibrin, thereby causing the lysis of the clot and the presence of the formation of the kinins, which is the cause of the pain associated in dry socket. So symptomatic management is what is the gold standard. So basically antibacterial dressing, oppurulent dressing, and topical anesthetic dressing is what is given to cover this. So the pathological aspect of this entire process is basically the fact where what we need to understand is the fact that when there is a traumatic extraction that is done, basically it leads to the formation of inflammatory mediators, which actually in turn actually cause the lysis of the clot, thereby initiating dry socket. So whenever so our aim as dental surgeons during an extraction procedure is to minimize the trauma that is involved. Okay, now let's look at osteomyelitis, which is jaw. So osteomyelitis, if we look at the term, osteo means bone, myelo means the bone marrow, and itis means inflammation. Now this is a dry specimen of bone showing the tooth apex, the orientation of the apex to the alveolar bone. So clearly this is the compact bone, right? The outer compact bone, and the inner component, which is the trabecular bone, in between which you have marrow spaces, which is composed of the marrow and the blood vessels. Okay, so as the Greek word goes, osteon means bone, myelos means marrow, and itis means inflammation, as I just outlined. So by definition, osteomyelitis is defined as inflammatory condition of bone that begins as an infection of the medullary cavity and the Haversian systems and extends to involve the periosteum of the affected area. So this is a cross section of the bone. So basically what you see here is this is a decalcified section of the bone, right, stained by hematoxin and eosin. This is the dense compact bone, right? This is the marrow spaces, bone marrow, and this soft tissue component lining the dense bone is basically periosteum. And periosteum is a thin sheet of dense fibrous connective tissue which contains osteoprogenitor cells that grow and heal the bone and is the main blood supply to the bone. Okay. So there were predisposing factors that affect that increase the chances of developing osteomyelitis. They're categorized as conditions that alter host defense, for example, debilitating systemic disease like diabetes, agranulocytosis, leukemia, severe anemia, malnutrition, drug abuse, alcoholism, sickle cell disease, and febrile illnesses as typhoid. Conditions that alter vascularity of the bone, which include therapeutic radiation, osteoporosis, Paget's disease, fibrous dysplasia, bone malignancy, metallic bone necrosis, and virulence of the organism. Basically, sometimes organisms that precipitate thrombi formation by virtue of the destructive lysozymes increase the chances of osteomyelitis to develop. So basically, predisposing factors means the factors in the presence of which there is higher chance of the development of osteomyelitis. So let's look at etiology. So when we look at etiology, odontogenic infections are most common etiologies for osteomyelitis of the jaws. Trauma, Infections of the orofacial lesions, that means infections, soft tissue infections of the orofacial regions, which spread through the facial spaces to include bone, to involve the bone, and leading to osteomyelitis. And lastly, infections derived by hematogenous route. That means infections at some other part of the body, which through hematogenous routes come and lodge themselves into the marrow spaces in the maxillofacial region, giving rise to osteomyelitis. So the most common organisms that are responsible for osteomyelitis are beta hemolytic streptococci, to a lesser extent gram-negative rods and anaerobes. Neonates are prone to infections with E. coli and group B. In the tropic, whole populations are at risk from Mycobacterium tuberculosis and Brucella species, and fungal osteomyelitis is, although rare, occasionally is caused by Aspergillus. So this is just some information. Let's look at the pathogenesis now. So acute inflammation, edema, and pus formation of the bone basically leads to increased intramedullary pressure. This increased intramedullary pressure leads to vascular collapse. That means the stasis of blood, ischemia of the bone, leading to avascular bone. This avascular bone is basically the what leads to is the end of what happens with osteomyelitis. Okay. So responses to infection, dead bone becomes encased with granulation tissue and it slowly starts to get resorbed. Bone resorption and bone death results in abscess cavity formation and sequestration of bone fragments. And sinus formation takes place, that means there are multiple draining sinuses, and also there is formation of involucrum and cloacae that are formed. So basically what is happening is, as avascular bone is formed or dead bone is formed, the body's response to this infection, this chronic infection, basically leads to the formation of granulation tissue around it. That granulation tissue that forms around the dead bone basically, okay, leads to further abscess cavity formation and sequestration of bony fragments. So basically these patients will have bony fragments that will be sequestrated through either the socket or through the draining sinuses. Okay, and involucrum basically is the formation of new bone over dead bone. Okay, so this is basically the response of the body to osteomyelitis. Okay, so this is the radiographic image of segment of an OPG basically. So here you can see the osteomyelitis myelitis lesion. This is the sequestrum, right? This is the moth-eaten appearance of bone that is visualized. If we take the histopathology of chronic osteomyelitis, what we basically see is granulation tissue, fibrin, and tissue debris surrounding spicules of bone. This bone is necrotic bone, so basically it's dead bone. So how do we identify dead bone under the microscope? Basically under the microscope, dead bone is identified by the fact that there is no osteocytes or no osteoblastic rimming that is seen, right? So loose connective tissue with infiltrate of lymphocytes and plasma cells is seen. So the presence of lymphocytes and plasma cells clearly indicate that it is a chronic infected lesion. So this is another histopathological image, right? So this is the chronic inflammatory cells that you're seeing. This is the dead bone that you're seeing. So this is basically showing you the hyper image of the chronic inflammatory cells, basically plasma cells, lymphocytes. Okay, this structure here basically is a blood vessel. So basically because it's collapsed here, it looks like a strand. So how do we manage osteomyelitis? Basically, you have conservative management and surgical management. I'm sure this is already being discussed by the surgery team. So under the surgical management, basically they do incision and drainage. So basically extraction of the loose or offending teeth is done, debridement is done, decortication is done, sequestromy is done, basically where the dead bone is removed and is surgically removed, and saucerization is done. So saucerization basically is a surgical process where the surgical site after the removal of the sequestrum is basically smoothened out using surgical intervention. The aim of it is basically to initiate healing, initiate bleeding and healing, so that clot formation is formed, and the surgical wound heals faster. Okay, so moving to the next lesion, which is central giant cell granuloma. So as the word suggests, central, it is always present inside bone. That means it's intraosseous, right? The words giant cell indicate that the microscopically we see giant cells in this lesion, and granuloma here is a misnomer. All right, so I'm going to explain it to you as we go along. So first of all, it's uncommon. It's a benign proliferative lesion. Etiology is undefined. So as I said, it is basically categorized as a lesion for which etiology is not known. All right, it's common in less than 30 years of age, more common in females as compared to males. Common site is mandibular anterior region crossing the midline. Now this is something very important to remember. It's among one of the very few lesions that cross the midline, okay, of the jaw. So the patient is generally asymptomatic. There may be cortical expansion and perforation may be seen in some cases. So it's classified as non-aggressive type and aggressive type. Radiologically, you see radiolucent lesions with smooth or ragged borders. Multilocular radiolucencies are seen. There's cortical expansion, perforation, sometimes displacement of teeth is also seen. Now, when you actually do the when we do a biopsy of these lesions, what we actually see is highly cellular connective tissue, multiple giant cells arranged close to blood vessels, and extravasate RBCs and hemocysteine pigmentation. Now this is a radiographic presentation, so you're seeing buccal cortical expansion, all right? This is an occlusal view of the mandible. You're seeing cortical expansion, you're seeing a lesion present over here. Microscopically, what you're seeing is hypercellular structures. These are the giant cells that we see. These are all fibroblasts and blood vessels of varying size and shape, okay? Now this is central giant cell granuloma. Okay, now let's look at the next lesion, which is Paget's disease. So Paget's disease is also called osteitis deformans. This disease is characterized by the abnormal and anarchic resorption and deposition of bone, resulting in distortion and weakening of the affected bones. Now, again, etiology is not known. There are probable etiologies such as genetic, which is autosomal dominant, viral, such as measles virus, and inflammatory causes. So, these etiologies are based on research evidence, with the fact that some patients, the biopsy specimens that have been evaluated have shown to have measles virus particles, so on and so forth. So clinical features common in the older age group, male to female ratio is 1:1. More common in whites because it's more. It has been majorly described in the Caucasian population. It's discovered in radiographs taken for other purposes, or with the fact that during routine blood examination, as the increased serum alkaline phosphatase levels are noted. Patients usually complain of bone pain, all right? Impaired hearing, tinnitus, change in vision, and cranial nerve palsies are common. Now, these symptoms and clinical features are very directly correlate to the pathology of this lesion, where there is regular resorption of bone, then there is again formation of bone, and this whole process takes place in phases. So various different parts of the bone, various different parts of the skeleton are commonly affected: lumbar vertebra, pelvis, skull, femur. Okay, so the affected bones become thickened, but they are weakened and enlarged. Okay, so the bone that is formed, the quality of bone, the level or the strength of the bone is not that much as a normal bone. Okay, the affected skull, again there's increase in the circumference of the head. So basically this is happening because there's a resorption taking place, and then there's newborn formation, resorption taking place, newborn formation. So this takes place in phases, as I just mentioned. So complications related to maxillary involvement are nasal obstruction, enlarged turbinates, obturated sinus, deviated nasal septum. So dentally, it's very common to see alveolar ridges that tend to remain symmetric but become grossly enlarged. So usually these patients complain with spacing in teeth. If they are dentulous, then you see spaces between their teeth. If they are edentulous, then their dentures very frequently don't fit them. Okay, and these patients keep coming back for to the dentist saying that I just got the denture done and now it's not fitting me anymore. So if there is a regular complaint of this sort, I think these patients, elderly patients, need to be evaluated for Paget's disease. Now, when you do a radiograph of the head and neck region, what you will see is decreased radio density and alteration of tubercular pattern. You see osteoporosis, all right, cotton wool appearance, something that is pathognomic for Paget's disease. Teeth often demonstrate extensive hypercementosis and alkylosis, and there is loss of lamina dura when you see it, the radiographs in IOP. So this is a classical lateral skull image of cotton wool appearance, all right, and the periapical radiograph where you're seeing hypercementosis. So this generalized hypercementosis. If you see a patient with generalized hypercementosis, we need to evaluate for Paget's disease. So when we do a biopsy, what are we going to see? Basically, again, we just got to correlate the pathology to what we should expect microscopic. So the core pathology in Paget's disease is resorption and formation. So basically, there is uncontrolled alternating resorption formation of bone. In the active resorptive phase, numerous osteoclasts are seen around bony tuberculae, while in the osteoblastic activity, formation of osteoid rim around bony tuberculae is seen. So highly vascular connective tissue stroma replaces the marrow. All right, there is presence of basophilic reversal lines, which I'll show you on the next slide. Okay, these reversal lines basically indicate the change in the phase between resorption and formation. Okay, and these reversal lines, because resorption and formation takes place alternatingly, gives it a jigsaw or a mosaic appearance of the bone microscopically. So these are basically the osteoclasts that you see. These are osteoblastic rimming, and these are basically the reversal lines. Okay, so if you look at this at the 2 o'clock position, these reversal lines basically make the appearance of the bone as mosaic. Okay, so there are serological tests that can be done to identify Paget's disease to support a diagnosis. Number one is elevation in serum alkaline phosphatase level. Normal blood calcium, there is normal blood calcium and phosphorus levels, but there will be elevated urinary hydroxyproline levels. Now, there are since these two markers are considered to be the newer sensitive markers, which is urinary N-telopeptide and alpha C telopeptide. So the presence of these two markers in urine is pathognomic of Paget's disease. So the treatment for Paget's disease, asymptomatic patients, basically is systemic therapy not initiated unless alkaline phosphatase exceeds 25 to 50% above normal. So basically, symptomatic treatment is done for the bone pain, aspirin or other analgesics are given. Parathyroid hormone antagonists can also help in relieving symptoms of Paget's disease, such as calcitonin and bisphosphonates. Of course, these drugs come with other complications, which you need to be aware of. Okay, let's look at the next lesion, which is called cherubism. Again, this is a rare developmental jaw condition. All right. So the difference between developmental lesion and congenital lesion is congenital lesions are present since birth, but developmental lesions arise along the course of the development of the child, and during the growth phases and the growth spurts, these lesions increase in size, and once the entire growth phase is over, developmental lesions are believed to regress in size. Okay, so that's the difference between congenital disease and developmental disease. What is the difference between yeah, all right. So inherited basically are any diseases that are transmitted due to from one generation to another due to a genetic deformity. Okay, so in cherubism, basically it's been identified as autosomal dominant trait. So that means if the father or the mother, any one of them has it, the next generation of children will have it because it is a dominant trait. So the gene for cherubism has been mapped to chromosome 4p16. I have mentioned in the past what is this nomenclature. So 4 stands for the chromosome number, P stands for small arm, petite, based on the French, American, and the British nomenclature of chromosomes. 1 and 1/6 stands for uh, chromosome number 4, short arm, a band A1, subband 6. Okay, so that's what this means. So basically, this is the address of the gene which is showing any kind of mutation. Okay, So when there is a genetic mutation, the protein that is coded at that location basically is altered, which actually leads to the formation of, which actually leads to basically the expression of the gene, which actually leads to the pathology. Okay. So facial appearance is similar to that of plump-cheeked little angels, that means cherubs, which are depicted in Renaissance painting. So basically, because in these patients, these are young children who basically have swelling of they appear very chubby, and they resemble these little angels from Renaissance paintings. That's why this lesion was named after them as cherubism. Previously, it was also described as familial fibrous dysplasia, but that's a misnomer. Okay, so this slide clearly shows a patient here with who has cherubism. All right. So what we're actually seeing is bilateral expansile mandibular maxillary lesions. Okay, this is basically a chubby baby. All right, and this appearance looks very similar to that of the cherubs or the little angels from Renaissance paintings. All right. Another important feature that can be visualized here in this patient is basically the visibility of the sclera under the iris. Okay, which is again something very typical of cherubism. So right? The clinical features for cherubism is patients usually are in the age group of 2 to 5 years age, right? Mild cases, diagnosis may not be made until 10 to 12 years of age. Clinical alterations progress until puberty, stabilize and slowly regress. So as I told you, this is described as a developmental lesion. So generally after a growth phase is over, it's believed that these lesions regress in size. Now, cherub-like feces basically means bilateral involvement of the posterior mandible that produces an angelic chubby cheek, right? So as I mentioned, eyes are upturned to heaven, wide rim of exposed sclera is noted below the iris. Okay, many patients have marked cervical lymphadenopathy. Okay, so mandibular lesions tend to involve the angle and the ascending rami, bilateral symmetrical, intraorally agenesis of the second and third mandibular molars, tooth displacement, failure of eruption, delayed eruption, premature exfoliation of deciduous teeth. Radiographically, you see multilocular expansile radiolucencies, right? You see here, all right. So in this patient, there's no involvement of the maxilla, all right, but you're seeing bilateral multilocular radiolucencies, all right. If you biopsy these lesions, okay, this is also described as floating tooth syndrome, okay, due to the numerous unerupted teeth, and many times ground glass appearance is also seen in this lesion, all right. So if we do a biopsy basically of this lesion, all right, both sides, if you take the sample would be the same, the visual, the histopathological features would be the same. You would see vascular fibrous tissue, variable numbers of multinucleated giant cells. All right, the giant cells tend to be small and usually aggregated focally. Okay, foci have extravasated blood. Stroma to be more is more tends to be more loosely arranged. There is eosinophilic cuffing that is seen around small blood vessels. So if you look at this and reflect, these microscopic features look very similar to that of central giant cell granuloma, right? So that's why the differentiating feature basically here remains the fact of is the clinical features and the radiographic features and the fact that it's a developmental disorder that actually regresses and once the child finishes his this is the histopathological image, not very clear, but you can see the multinucleated giant cells and the cellular hemorrhagic mesenchymal. So treatment and prognosis, remission and involution after puberty, surgery is rarely indicated. Okay. Okay, let's now look at tumors of bone. So benign tumors of bone, the most important one is osteoma. So osteoma is the proliferation of compact or cancellous bone, endosteal or periosteal location, rarely in soft tissue. So as well as circumscribed swelling, slow growing, producing asymmetry. Radiographically, you're going to see a radiopaque mass because it's a bone tumor. Histopathologically, you'll see compact or cancellous bone, which is normal bone. It's basically overgrowth of normal bone. So once you surgically excise these lesions, they do not recur. This is an example here of an osteoma in the maxilla. Okay. Now this is a very common lesion that is actually seen in leisure, and this is described as a palatine tori, okay, or Taurus palatinus. Okay, this is basically a hematomatous bone. Okay, is hematomatous bone. That means it's normal bone, excessive growth of normal bone. This is not a tumor. It is not an osteoma. It's basically excessive growth of normal bone. Okay. So you also have it as Taurus Mandevillaris. Okay, commonly seen in the lingual aspect of mandibular premolar region. Okay. So they are hematomatous lesions. Okay, racial, hereditary, and environmental factors are considered to be the reason for this overgrowth. Um, Globally, in various different ethnicities and races, these lesions are common. Okay, there's no evidence of malignant conversion. They do not have significant growth potential, unlike neoplasms. They come in various sizes and shapes. There are many different papers that have been published, even from Malaysia, on characterizing torus. Surgical treatment before prosthetic appliance is given is something that's very important. One benefit, or I should say, a collateral benefit of this lesion is the fact that these lesions are a good source of for bone grafting, right? For maybe implant surgeries or even periodontal surgeries, right? So this is a very good source of bone graft. Okay, so let's look at the malignant tumor. The most common malignant tumor is osteosarcoma. All right, it's a malignancy of mesenchymal cells that have the ability to produce osteoid or immature bone. Now, sarcomas are highly malignant. All right, osteosarcomas have very poor prognosis in the maxillofacial region. Okay, they can originate intramedullary, that means inside the marrow spaces, juxtacortical, that means adjoining the cortical bone, all right, or extraskeletal, that means in soft tissue. Okay, now which is extraskeletal, which is very rare. Now, clinical features: 6 to 8% of all osteosarcomas in the body occur in the jaw. It can occur at any age, common in the third to fourth decade of life, male predominant. Now, the maxilla to mandible frequency is the same. Okay, generally affects the posterior region. Swelling, pain, loosening of teeth, paresthesia, and a history of slow growing mass in the jaw is commonly noted. Okay, radiographically, it varies from dense sclerosis to mixed sclerotic to radiolucent lesion. Border is ill defined and indistinct. Now, this is something very characteristic that I have time and again said. Okay, well defined radiographic lesions generally indicative of benign lesions. Ill defined, right? Ill defined lesions, all right, are basically, and indistinct borders are indicative of aggressive lesions, right, and suspicious of malignancies. Root resorption may be seen in some case, again indicative of aggressive lesion. Classic sunburst appearance is seen due to osteophytic bone production on the surface. Now, this is a pathognomic appearance of radiographic presentation in osteosarcoma. Now, this is a patient here who came with swelling of the jaw. Now, the swelling increased rapidly in size. If you notice here, there is displacement of the teeth, right? It's a massive swelling over here. Now, radiographically, a lesion like this, osteosarcoma of the jaw, would present as an excessive expansile lesion with, periosteal reaction, which is described as sun ray. So this appearance is basically because of the formation of osteoid, that is tumor bone. Okay, tumor osteoid. So histopathologically, what are you going to see? Because this is a sarcoma, basically there's proliferation of atypical osteoblast, malignant mesenchymal cells. Now these cells show pleomorphism, hyperchromatism, mitotic figures, which are common atypical features that are seen in many malignancies. Okay, areas of tumor osteoid formation is also seen. There are various different histological variants. There's osteoblastic, chondroblastic, and fibroblastic. Just good for you to know. So this is an example of an osteosarcoma here. So this is the mesenchymal malignant cells. Do you look at this? This is a pleomorphic atypical cell over here. Now this is a high power picture here, clearly showing you mitosis, hyperchromatism. Look at the size and shape of the nuclei, uh, clearly indicating the highly malignant and atypical nature of osteosarcomas. So osteosarcomas are malignant tumors of bone. Okay, they're rare, but as an undergraduate, we need to know about it. and we need to learn about it. So in terms of treatment, basically the treatment is surgery, all right, and the prognosis is poor because sarcomas spread rapidly through the vasculature, and the patient has metastasis and basically dies of complications secondary to the malignancy. Okay, that brings us to the end of this topic. Thank you very much. We will discuss further in the CBL.